going to say something? Are you going to introduce me or I introduce myself?
I prefer that you introduce yourself. Easily. Hi, Esteban. Good morning.
Hi, Pablo.
How are you?
How are you doing?
I'm doing well. How about you in these crazy times in Costa Rica?
Oh, it's been a very hard time, Pablo. It's difficult not working, but we need to stay home for a little bit more in order to keep things better.
Okay. I'd like to thank you for accept my invitation for this live, this international live, and I'm really grateful for help our hospital with all the donations. Please introduce yourself and take your time. It is your lecture right now.
Thank you very much for your invitation, and it's my pleasure and my honor to share something with my Brazilian friends, which I really like and appreciate. I have learned a lot from the Brazilians, and I keep learning from you guys all the time. So thank you very much for this great opportunity to show some things and talk about orthognathic surgery, which is what we like. I don't have a lot of things to say about me. I'm an oral surgeon or a buccomaxillofacial surgeon like all of you guys. My practice is focused on orthognathic surgery, and I'm most of the time doing virtual surgical planning. So today I'm going to be talking about orientation of the patient in the virtual environment, and I'll use some asymmetric patient cases to show this. So you just tell me when can I share my screen and we can begin, Pablo.
Okay, it's okay. Can you share your screen? You can share.
I can share my screen now? Okay,
yes.
Give me 1 minute, please. And please let me know if it looks good and if you can see everything.
Let me see. Yes, okay.
It's okay now?
Yes.
So as I say, I'm going to be using some asymmetric patients to show what we do with the orientation of these patients and what are the advantages of the virtual environment and how can we squeeze the software and try to get the best results. So I'll be talking about this. I think I have very similar protocols to my good friend Pablo Leite. We usually have discussion on cases and what he's doing and what we are doing here. The same with other friends in Brazil, like Dr. Santana, Dr. Octavio Sintra, Dr. Pablo, and some other friends. Wait a minute, I'm gonna change my chair 1 second here. I'm ready.
Are you at the office right now?
No, I'm not at the office. I'm staying home.
Okay.
I'm staying home the full week, the whole week. So let's talk about facial asymmetries right now. So this is what we usually do. We take the records. The records are probably one of the most important steps. And here I'm trying to compare different records with closed lips and with relaxed lips. We are always trying to get relaxed lips patients to our records. I really want to see how the lips are relaxed, and usually when the patient is closing the lips, they are not absolutely relaxed. So I like to take photos with the lips relaxed. In order to get these lips relaxed, I usually get a bite wax, which the patient will be biting for some minutes. After some minutes biting, his lips will, or her lips will get relaxed, and it will be easier to take the photos. So as you can all see, this is a facial asymmetry with a deviation of the mandible to the left. You can see the control points. We have two control points, which are very important because this is what will help us to calibrate the image. We have 2 points in the frontal view and we have 2 points in the lateral view in order to calibrate our images. So we can see also a long face, which is probably the main concern of the patient. She says, I'm debated and I have a very long face. I'd like to change that. And a little bit of gummy smile that we can probably manage with our surgical management. And this is the bite, the classical bite of an asymmetric patient, inferior midline deviated to the contralateral side of the condylar hyperplasia. We usually don't go into the TMJ to do surgery in these patients. We usually let them grow, and once we have 1 year with photos following these patients with no changes in the midline or in the facial appearance, the end of that we will go for surgery. So we are not doing a lot of TMJ high condylectomies or shavings at the mandibular condyle and those things. Usually when we get our patients, it has already stopped, or if we are looking at some changes, we'll wait a little bit if they are older patients. If they're young, probably we'll go into the condyle. We'll be trying to take the midlines, which are extremely important in our orientation protocol. The upper midline is very important. We don't care about the mandibular midline because we know we have the joints. This means that this mandible can be anywhere. So the only accurate midline is the upper midline, and we'll be taking the midline. And sometimes it's not that easy in the asymmetric patients because the philtrum, which is what we use as a reference, has changed because of the asymmetry. And we do forced symmetry test, which means we will push the mandible to the other side and put a bite there just to see how it looks. And if we can see here, the philtrum changes with this maneuver a little bit. Usually it goes more to that side. And this is something normal we see in our asymmetric patients, that we can get the midline a little bit shifted to the opposite side if we don't take consideration of these little details. Evaluation of the midline should be dynamic too. We should take the midline in smile, and here is our patient smiling. So with all this information, we'll go to the virtual environment. We'll do a 2D cephalometric treatment plan as we have been doing for years. And everyone used different references here. There's not a law to say where the upper incisor should be from back to front. Some people use glabella protocols, like stated by Andrews. Some of us like true vertical line, through subnasale, as stated by Dr. Bill Arnett. And so we have different options here, and everyone will plan as his school or as his beauty sense in his mind tells him where this incisor should be, upper incisor. And as we are talking, there's not a law where it should be in the space from back to front. These are movement. We are usually doing counterclockwise in order to reduce this vertical height of the face and get some projection of Pogonian. Here are some of our measurements. As you can see, we control the occlusal plane, which in my opinion is probably the most important thing to control in order to control facial aesthetics. We don't want those big maxillary advancements where we get fullness in this area, in the paranasal area and the nasal base, because we destroy patients' face. They look like very full in that area. They look like a monkey. We don't want those kinds of faces. So we're doing a lot of counterclockwise in order to control anterior nasal spine. Here is our final plan. And here is our orientation. And so what are we gonna do in the orientation? We're gonna put all the information we get from our records. And if you can see on the left side of your screen, you can see maxillary 3 down. That means the cant. In this case, the cant was on the right, 1.5 millimeters. Maxillary midline was 2 millimeters to the left, and there was a yaw, a big yaw, and yaw is something we are not related to, and we'll be talking about yaw in some other cases today. So this is the information we get from what we measure in our patient. And if we put this information into the software, the patient should look orientated as we consider the patient orientated clinically. Then you can do little adjustments and change little things just in order to get it really similar to what you are seeing at the clinical environment. You know, you are going from the clinical environment to the virtual environment. So you're putting all this information from your records into the software. And it's important to have a good orientation because it's the start point. If you can do a great surgery, but if your orientation is not good, at the end you have your midlines wrong, your cant wrong, or your yaw will be getting you in trouble. And so here we have a better view of what we were talking: maxillary cant, maxillary midline, and maxillary yaw. So this is the most important measurements we pay attention when we are measuring our patient in the clinic: maxillary midline, cant, and yaw. And so that's midline, cant, and yaw. And that's the most important thing we will use to orient our patient. All of them are points in the maxilla. And why are we using the maxilla? Because it will not change. The mandible can be anywhere. We have the joints. The patient can be that way, the patient can be that way, the patient can be that way, the patient can be that way. And that will never happen in the upper maxilla because it's just a constant, it's not a variable. And so we are using those three landmarks, midline, cant, and yaw of the maxilla to begin our orientation process. Then we will do a little bit of zygomatic arches and those things just to see that the orientation looks good. So here is our orientation. And I want you to pay attention to the movements when I just correct the midlines. It's like a big movement, just going from one side to the other. But we know that this is not the real life. We do not correct asymmetries like that. We need to have some point of rotation. So now I'm gonna level the cant. If you see, when we level the cant, it's a small movement. It can be like counterclockwise or clockwise. It depends on where your chin is going or which cant are you leveling. A frontal, no, it's frontal like that. Like that, it can go clockwise or counterclockwise. The chin will go like that. In order to level the canines that are here, it can go like that or like that. And then we'll correct the yaw. And you see how big the yaw change. Now I'm gonna see it from beneath. This is probably my favorite view to evaluate asymmetric patients because I can see the mandibular outline and the mandibular border in an easy way. And I think if we have a good mandibular outline and a good mandibular border, probably the result will be really good. So let's correct the midline. You see the big change. Now we'll level the cant, small movement. And now let's see how the yaw is gonna correct all this. You see how the yaw is correcting all this? Okay, and this is what the software is just doing, but I need to understand the software and I need to be enough intelligent to know that probably I can do a better correction of this yaw. And that if I go to surgery with this plan, probably my angles are going to be asymmetric. And I'll have a patient with a nice midline in the chin, but one of the sides will look a lot bigger. So that's why we are trying to pay a lot of attention in the jaw. I will correct the jaw with my hand just to make it symmetrical. And I love this tool, which let me know if I'm being symmetrical enough. And I always use this tool, this white curved line that helps me visualize what I'm doing. Then we'll go to the maxilla, and if you can see, we will advance the maxilla, and we will correct the yaw too. Here we see how it goes to the right side of the patient on the left side of your screen. So this is what we have done. This is the initial mandible against the final mandible, just to verify if our movement is being big enough and it will compensate that huge asymmetry in that face. This is my final maxilla. That's how everything will look. And here is our patient once we finish our surgery. So I think we have a good result with facial aesthetics, nice facial balance. We are not doing a nose job in this case because the patient don't want a nose job. The profile looks good, and we eliminate, or we can control, that long face appearance that was one of the main concerns of the patient. So I think we can have good results with this protocol. It's easy. The software will be doing most of the work for you. You just need to follow step by step and understand what you're doing. Because the main problem I think we have with virtual surgical planning is everyone wants to go into virtual surgical planning, but they don't understand what they can do or what the technician can do for them. So it's very important to understand what we are doing. And here is our patient. Let's look at the symmetry again. So we can achieve good results. And here is our occlusion. This is our final occlusion. If you can see, you have some pink elastics in specific brackets. That's what we are, that's where the patient should use her elastics after surgery. We like to put color elastics in the brackets. She needs to put the elastics so she won't get lost, as sometimes happens. It's scary when one patient don't know where to put the elastics. He put it wrong and he changed a little bit the bite. It will be corrected, but if your final bite was good, but we try to avoid that, okay? Now I'm gonna show an example where I don't get a very good result because I have some problems with my orientation. Okay, so this is another facial asymmetry, a huge asymmetry. And if you can see, the midline, the upper midline is shifted to the right. I don't know exactly how many millimeters it was shifted, but I'm really sure I have some problems when I say it was just 1 millimeter to the right. This midline is probably not 1 millimeter. If you see the patient and you see the philtrum, probably it was 2, 3, or 4 millimeters to the right. So I put this information into the software. I give my upper midline, my canines, and the maxillary yaw. And I just give 1 millimeter, which was too little, I consider. I will check everything from beneath, as I told you. And this is my orientation. This was during 2014. So Costa Rica was at the Brazilian World Cup and we're doing very good. That's why I paint my school with the Costa Rican flag. We enjoy a lot that World Cup. So I'll put the orientation and I'll be doing all my movements. I'll do the movements, and I think I'm going symmetrical with this patient. If you see, I impact the maxilla in order to correct the gummy smile, and I'll impact my maxilla, correct my midline, but it was such small correction of the midline, and we will see the final problems with that. This is what I look. I think it looks good. I can't get better symmetry than that. Maybe I can get a little bit more yaw, but I feel comfortable with that. So I was doing that. And this was my final chin compared with my initial chin. And I think it's a huge change, and probably the patient will look good. Okay, our final splint, it's a huge change. And here is our final result. Okay, and here is our patient. And if you see, the result doesn't look that bad, but if you really pay attention, you can see that the upper midline is to the right by 3 or 2 millimeters, and the patient is happy. She don't cares about it, but I can't stop looking at that. You know, like the patient comes in and you're the surgeon and you're just looking at that and you can't understand what happened. Well, it's easy when you do virtual surgical planning. You can go back and check what's happening. So if we evaluate that upper midline, the chin might be not perfect, but it's a lot better. But the upper maxillary midline is shifted definitely to the left, to the right. And what's the problem here? We have an orientation problem. We have a huge orientation problem. I just put 1 millimeter and probably it was 3 or 4 millimeters. You can see the result. The patient is happy. It's not being a big problem or a big deal for me, but I think a case that could be ended almost perfectly ends up with a shifted midline, and that's make me really sad. At least now I can understand what's happening and how can I correct that. And I realize that virtual surgical planning helps me become a better surgeon because I can check all those things. The profile, I do what most of you should probably do. And we have a nice profile. I'm always using a true vertical line through subnasal as a reference. I want my upper lip to be a little bit in front, my lower lip almost touching, and the chin in women will be 2 to 4 millimeters back from that line. In men, it will be in contact or it will be in line with this reference. Okay, we change that big long face appearance, which is helping to facial aesthetics and make the patient looks younger and makes the patient looks better. And here is our smile, and here is our final bite. Here is the bite of our patient. This is the bite before, the bite after surgery, and the bite after 2 years. We have good occlusal key, and I think that's what really helps us have stability in time. If we don't have a good occlusal key, probably we will not have stability. So we need to have good occlusions in order to have stability in orthognathic surgery. And sometimes if the patient don't have nice cusps or things, we will need the prosthodontist or we'll need a dentist to help us make new cusps, or we can do it if it's necessary, just in order to have stability in the long term. Let's look at some cases. These are before and after. Before and after taking care of that midline. Before and after. Well, smiling before and after. Long face, a little shorter face, gummy smile, and correction of the gummy smile. And occlusions should be tight enough to hold by themselves for a long time. Let's look this guy, it's the same problem, huge maxillary protrusion, a little bit of mandibular deviation. We'll put the information again, same protocol, and get some good results from the aesthetic point of view. All of this using the same protocol. We can use some coadjunctive procedures like grafts. I think lipofillings is probably one of the most useful tools. I don't used to use it a long time ago. I just began using it. I didn't have a lot of experience, but I think it helps with these asymmetric patients where we need to also compensate some soft tissue issues because the soft tissue for sure have changed. If we get a good midline, if we get a good cant and a good yaw of the maxilla, probably the mandibular outline will look good because it mirrors the maxilla. It usually mirrors the maxilla, and what we see in the maxilla, we will see it in the upper jaw, okay? Some different asymmetric cases where we have very different sides of the face, where the right side of the face is one patient and the left side of the patient is another person completely. I like to show the patient this. So I'm always doing this kind of exercise. I'll cut the patient in the middle and I'll do a mirror of the left side and a mirror of the right side and show her how different her face is. I'll show this to the patient and I'll tell, okay, in this side, we have your right face, and on the other side, we have the left face. And if you can see, it's absolutely different. It's two different persons. It's hard to get symmetry in these patients. She also has a problem in her eyes. And we can try to fix this, but it's going to be hard because we cannot correct the dystopia, we cannot correct the convergent strabism, and we'll try to work on that, but it's not going to be that easy. Okay, most of you probably know this paper from Dr. Edward Ellis, where he talks about fracturing the lingual segment in order to avoid condylar sac, or in order to avoid a huge torque to the condyle. So we use it in these cases. And this is another advantage that we have with the software. We'll plan with the software, and then we can know where we are going to have our contact areas. And we build the contact surface. And when we go to the operating room, we already know where we should trim or where we should do the cut. And it's really helpful. It's really, really helpful because you have already an idea of what will happen in the operating room. And it helps because sometimes it's not that easy to find these contacts in the operating room. So let's look at the result. This is our profile after surgery. At that time, I like more straight profiles. Now I'm going a little bit backward with the chin. I like smaller chins in girls. I think it was part of my experience curve. You know, I want to put those chins in the line and be sure that what I was doing with virtual planning is what I was doing in the operating room. So this is our lines, reference lines. And here is our patient after the surgery. We have a nice upper lip exposure. In a young patient like this, we are looking for 4 or 5 millimeters of upper lip exposure because she's really young. We know that upper lip will lengthen and will become longer every year as she ages and she becomes older. And we have a good correction of the upper midline, and that helps us in order to have more symmetry in the lower jaw. Here is the smile. We have the patient smiling. Here is our 3/4 view. And the bite after 2 years, this is six months after surgery, and in the lower jaw we have 2 years after surgery. So I'm not sure if that midline moves a little bit, but it stays there. You can see it from one to the other one. And we have good indentation. We have tight occlusal key, and that helps us to keep with these results for a long time. If we don't have good occlusions, all this might be lost. We like to compare our cases before and after in order to compare with our plannings. I have planned a vertical reduction I didn't do in this patient, but I want to see how accurate I'm being with comparing my treatment plan with my final result. And usually we are pretty accurate. Some things change usually in the proximal segment, because we know we can put it wherever we want in the operating room, and the software is not giving us that position. The software is giving us the position of the teeth. We are always doing mandible first. So I think that's make it more accurate, because let's suppose I take my records and my condyles are not seated. When I go to the operating room, the patient gets relaxed and the condyles get seated, and I don't have seated condyles in the fossa while I was taking my records. The only thing that will happen is that I will have a bigger gap. That's all. The condyle goes back, but the teeth will end up where I plan. Okay, some other cases, same protocol. We correct the upper midline, the upper cant, and the upper jaw. Then we'll put the mandible to this relation, and usually you have nice mandibular border results and nice mandibular contour. Okay, the bite after 6 months, and the planning and the result we get from the plan. These are different kinds of asymmetries. These are more vertical asymmetries, where the right side of the patient has grown, but more in a vertical vector. It looks more like a hemimandibular hyperplasia. And sometimes we need to do cuts here in the mandibular border. Sometimes we didn't. Sometimes we can compensate with the chin. And let's see this patient and let's do the exercise we like to do. On the left side of your screen, you have his right side face. On the other side, you have your left side. You can see one face is long, the other one is short. And we'll try to get symmetry with this patient. And if we look at the CBCT, we will understand a lot more of this kind of asymmetries. This kind of asymmetries, we have a long dental alveolar process on the right side. If you measure the dental alveolar process on the right side compared to the left side, it's going to be a lot longer. So it's a vertical issue, and it never crossed that midline, and you have big condyle on that side, and it has pushed that angle to the midline. And if we see it from the back, we can realize this. You can see how it pushed that angles close to the midline in these hemimandibular hyperplasia patients. And to do this, we need to compensate these asymmetries doing some maneuvers. We can cut the mandibular border. It's a good option. The thing is that the inferior mandibular nerve is very inferior in these patients. Sometimes it's not that easy. In this case, we go for surgery. We perform our orthognathic surgery to correct the lip, the upper lip, and here is our final result. And we will see what we do. Now we are going to compare both sides of the faces, and we see we get pretty good symmetrical mandibular outline or mandibular border in this patient, which makes us have more symmetric faces when we do this evaluation. Okay, we can see the upper midline is corrected, the cant is corrected, and here is what we do. We try to compensate with a small cut in the mandibular right side, and going down on the left side, we'll graft all that space, all that will be grafted, and we will compensate this like that in order not to be doing a bigger or a lot bigger cut in the mandibular border. And we can see our before and after to compare how this mandibular border goes symmetrical after surgery. Okay, let's look at the final case. This is a young patient who comes for us asking about or concerning about her long face and about a mandibular deviation to the left. We can see some nice facial features, and we can see the bite of what an asymmetry looks like most of the time. She has very strong upper lip and lower lip. Those lips are really strong. It's not easy to take decisions about going forward with those big lips or going backward with those lips. Now women like full lips, so I think it's something we need to learn how to manage these huge lips in order to have good results. And there are patients who have really nice structures, and it's not only the position of the structures, it's also the quality of the structures, because you can correct and put the structures in the perfect position. But if the quality is not good, then your final result might not be that good. So we are, in this case with a patient, we know she has a lot of potential to have a good result, because she has a missing position of the structures, but a nice quality of every facial structure. So we'll do the evaluation, and if you pay attention at the smile, you can see that the upper midline is shifted to her right side, and she has a lip cant where the cant, the commissure of her lip is lower on the right, it's upper on the left. And usually when we see this in the lip, we want our maxilla to be like that too, you know. We want to have a maxillary cant going in that way, but sometimes the orthodontist, they are trying to put the occlusal plane or the maxillary occlusal plane straight, and they can go like that on the other side. And if you pay attention here, we have that. We have a lip cant on one direction, and we have a teeth cant on the other direction. So what I'm going to take from this, I'm going to take the cant of the maxilla, 0.5 millimeters down on the left, and 2 millimeters to the right, a deviation of the upper midline. With this information, I can go to the software and I can do my orientation. 0.5 millimeters and 2 millimeters to the right, the midline. I can do all this because I understand I can go from my clinical records to the virtual environment and then come back and check until I feel comfortable, and I see that one of them looks just like the other. So this is what we are doing. This is going to be our orientation. We feel comfortable with that orientation. Now we just need our software to help us get that position, and then we will go to do this in the operating room. 2 millimeters to the left, 0.5 millimeters down on the, 2 millimeters to the right and 0.5 millimeters down the cant on the left side. Here we have the orientation, and now we're ready to go for surgery. This is more or less how the panel of the software looks. We'll be doing the lateral X-ray and the cephalometric treatment plan, as we know. Here is our plan. We'll do a small maxillary advancement, 3 millimeters. We will go a little back and correct our mandibular deviation. And we'll do a small vertical reduction of the chin. So here we are. We're going to import all that. And now we're going to do the frontal movements, and you all will see how the mandible moves to the maxilla. When I just ask the software, I just go with that checks, and I say, okay, correct the midline, the facial midline, level the mandibular canines to the facial horizontal, and set the yaw or correct the yaw. I don't use a lot of yaw in this case. So everything will go there. And now the mandible is corrected. Now I have the final mandible, the initial mandible, and I can see how it looks. Looks good, I like it. I want to check that my canines are level to the facial horizontal. Then I'll put my maxilla. I'll go for this view all the time. I will always do this. This is the best view for asymmetric patients. And if we can use the tool, it will be great. This tells me I'm doing what I think I need to do. I need to do the left side of the face longer in order to correct the chin position. Now I'm going to correct the midline and the cant of the upper maxilla. You will see this. You will see how it changes the midline, the cant, and a little correction of the yaw in this patient. And once we have everything ready, we check that we correct that midline, that cant, and that it looks symmetrical for us. We'll do a vertical chin reduction, and we'll go to surgery with this plan. I'm always using this tool. I love this curved white line that I can use from this view. And it's really helpful. If you are using any software, try to get this tool. It's really, really useful. It will help you a lot with getting into the yaw thing that it's not that easy to understand at the beginning. We have our final position, initial maxilla with final mandible. We will do the splint. We are always doing intermediate splint with mandible first sequence, and we are never using a final splint. We just use intermediate splint, and our final splint will be the occlusion of the patient. And we go for surgery, and we will be looking at the result of this patient. Here is the final result. I think we have a shorter face. We achieved what she was looking for. We have a nice mandibular border. I think it looks good and symmetrical. If we evaluate the dental midlines, we have done the correction of the upper midline. You can see it here. And it was a concern about those big lips, how that lip will look after surgery. And this is the result we have. It's a really nice result. If I use my references, that upper lip is a little bit to the front from what I want, but in my opinion, it looks good in her face and with all her facial aesthetic items. This is the 3/4, and as you can see, we do the vertical reduction of the face. We have a nice anterior incisor exposure. We are always using a vertical reference. We always want to have nice anterior exposure in repose. That's how every plan begins, with the position of the upper incisor. That's how everything begins all the time in every plan, not only in orthognathic surgery. I think it begins like that in prosthodontic specialty. I think it begins like that in orthodontic. So we are always taking into consideration the position of the upper incisor, and we always want to have upper incisor exposure in these patients. And the smile, and then we'll go to check the occlusion. You have the occlusion 2 years after surgery. And here we can probably do some equilibration and bond some cusps in the posterior area in order to have a more tight occlusion, more in the right side than in the left side. But it's a really good occlusion which will keep stable during years and years. And that's what we're looking for, stability in long term. Just as a conclusion, I think that the orientation should be realized based on clinical numbers we take from the patient. And we must understand we can go from these numbers to the virtual environment. And if something done looks good, we can go again to measure the patient, and we can have the patient live there seated with us. And we both will be doing the orientation in order to have a really good orientation, because it is the start point of every treatment in orthognathic surgery virtual environment. And midline, cant, avio, and yaw of the maxilla are probably the most important measurements we take to do the orientation with this easy protocol to orient the patient. So this is where we're gonna take a lot of time to evaluate the midline, to do a dynamic evaluation of the upper midline, and to see the cant of the face and the yaw. So this is what I want to show a little bit about orientation with some cases. I hope you like it. And thank you very much, my very good friend, Pablo Leite. It's a honor to be with you and some of your friends from Brazil, because I'm pretty sure you are great surgeons. Thank you very much.
Thank you, Esteban. Congratulations for your lecture. I really appreciate a lot your cases. They are really great cases. And I would like to ask you a question to you. It's okay?
Sure.
I have a question. In your training program, did you learn maxilla first or mandible first?
I learned both. I go through some hospitals. I was trained in Bogota, in Colombia, and in some hospitals, most of them doctors want to do maxilla first. Then I go to another hospital where the professor, he was doing mandible first, his cases, and I begin to learn about mandible first. I begin reading. I begin to understand more about mandible first, and I think it's an easier approach to what I do. When I go with the counterclockwise, it's a lot easier for me. I do a lot of multi-segment Le Fort 1, and it's a lot easier because I have the mandible, then I just do the multi-segment and get the occlusion. It's a lot easier, and I think you can be more accurate, because if you have a variable like the mandible, I consider the mandible a variable, it can be anywhere, and I consider the upper maxilla a constant. It will never change the position. So I think I can be more accurate if I go with the variable to the constant, that if I decide to go with the constant, I cut the maxilla, now it's a variable, and I am going with the constant to the variable. So I think I can be more accurate if I go with the variable to the constant. And that's why I like it more. But I think you can do maxilla first or mandible first at the end. Everything will be related on how good your records and your plan is.
Okay. stop to share your screen.
Sorry. Wait a minute, Pablo.
Green. Share. Stop share screen. Go down.
I'm looking for it.
Close your keynote. Close your keynote.
I think I'm not sharing any.
That's okay. And my second question, in head orientation, do you prefer to use dynamic evolution of the soft tissues, or you prefer to use the static evolution of the soft tissues? What do you consider?
I think I need to use both, Pablo. I think I need to use both. You know, it's like I always take them on static because it's really hard to take them on evolution, you know, or dynamic. The patient smiling and things like that. It's not that easy to measure something. They always tilt their head. You say them smile and they go back, or they go to one side, or they go to the other side. But I try to take my records with the patient in front of me. I'll measure some things. Then I'll be talking with the patient to see if when he talks, something looks different, if something changes. So I think we need to use a little bit of both. You know, it's like you will measure the patient, but then you will be him. You will try to talk and evaluate what he's doing, how he postures his head, what changes he do on dynamics. And I think you need to get a little bit of each world.
Okay, I agree with you.
Yeah, you do the same.
It's same, and I consider the both dynamic and static evolutions, probably or mainly because sometimes if you consider just the dynamic evolution, you can do some mistakes at the planning, and because this I prefer to consider both.
Yeah, I think so. I think I try to use a little bit of each one.
Okay. Esteban, thank you so much. Appreciate a lot.
No, thank you, Pablo.
For your hope.
You like it. It was a little bit of orientation and what we have been doing. I know you do it pretty similar for a long time. So it's my pleasure.
Okay. Thank you, Esteban. Bye-bye.
Okay, bye-bye, Pablo. Are you going to keep going with your lecture now?
No, it's finished now.
It's finished? Okay.
Okay.
Bye-bye.
Bye-bye.
Nice to see you. Nice to see you again.